Hi, my name is Dr. Jack Burt. I'm an adjunct clinical professor at the University of Minnesota School of Medicine. I founded the Cartilage Restoration Center of Minnesota about 10 years ago, and I'm past president of the Arthroscopy Association of North America. My charge today is to talk about hyaluronic acid preparations with higher molecular weight on patient outcomes, and we're going to discuss some new evidence that has been published. I have no financial relationships to disclose relating to the subject matter of this particular presentation. So the learning objectives today are to explore novel management strategies to preserve mobility, improve patients' quality of life, reduce the effects of potential disease-related comorbidities in patients with osteoarthritis of the knee. We're going to investigate the viability, cost-effectiveness, and safety of viscosupplementation with hyaluronic acid injections as an alternative for the treatment of osteoarthritis of the knee. So if we look back in the literature, there are really two large databases where if you enter a CPT code, you can actually extract data. One is the Pearl Diver database, which is the largest, and another is the United Healthcare database. And this is a study from Dewan, the Journal of Arthroscopy in 2014. What they did is they looked at roughly 12,800 patients who had total knee arthroplasty with osteoarthritis in a single year. And during a 5-year time frame, 10% had had physical therapy pre-total knee replacement, 2.6 got an unloaded brace, about 0.5% underwent acupuncture, but about 43% were administered intra-articular steroids, and 15% received viscosupplement injections. The bottom line to all of this is that about 59% did receive some type of injectable medicine prior to their total knee replacement. Now, one thing we know for sure with a lot of the arthroscopic data that has been collected is there's clearly an earlier age of onset associated with increased duration of treatment with respect to osteoarthritis. We used to think of osteoarthritis having an estimated average treatment duration of only about 3 to 5 years. Well, the truth of the matter is, now that we know that just even removing 10% of the meniscus, for example, in professional athletes, causes grade 4 changes, or up to 30% is noted in some of the 17-year follow-ups that have been published after an arthroscopic meniscectomy, patients will develop arthritis of the knee and development of grade 4 lesions in a significant number of cases after a simple meniscectomy. So if you look at it from that perspective, we really have an estimated average duration of treatment for a minimum of 23 years. And I'd make the argument that's probably longer or up to more than 30 years now due to the fact that we have people living in their late 80s and early 90s. Is there a high level of residual symptoms in young patients after total knee arthroplasty? Well, this is a study by Parvizi from Philadelphia at the Rothman Institute. And he looked at a group of patients, 661 of them, 1 to 4 years after total knees. Of interest was only about 2/3 of them felt really good. About 33% still had pain, and about 41% still had stiffness. So the bottom line is they still had difficulties after their total knee replacement. And if you really look at the literature, there's about 14 articles that have been published over a 7-year time frame, which shows that about 11 to 20% of total knee patients are dissatisfied after surgery. So it is not a perfect operation. And our goal is to try to avoid total knee replacement as long as possible in patients, especially now that they have a longer longevity of life. If you look at the limitations of osteoarthritis treatment options, the various limitations are, as noted on the bottom of this slide, poor patient compliance. Weight loss is almost impossible. All of us have had the experience of having a patient come in and say, gee, doc, I can't exercise because my knee hurts. And they're basically significantly obese. Yet they don't want to diet. And exercise is difficult for them unless you do kind of an isotonic approach. So it's very, very difficult to get patients to comply with weight loss and exercises. High doses of acetaminophen can cause hepatotoxicity. About 4,000 milligrams per day has been reported, to causing significant liver failure. Non-steroidals have a 17 to 19% incidence of gastrointestinal complications. Some have CV effects and renal complications. So as you move along and look at this slide to the upper left in the box, we tend to use a lot of topical non-steroidals, intra-articular steroids, viscosupplements, platelet-rich plasma, and stem cells. Limitations of use include side effects such as localized skin reactions, local pain, and post-injection flare. And the truth of the matter is, with stem cells, knowing with the FDA restrictions now in the US, we are now not allowed, to culture and expand those cells like they can in countries like Colombia and other Latin American countries, where they can get up to 20 million stem cells, and we're limited to perhaps 500,000 to 1 million, using fat as the primary source or bone. So that kind of leads us over to the final conclusive treatment modality, which is total knee replacement. This should be end stage. And as we've pointed out, patients really don't get great results in up to 20% of cases. For those of you who want a brief review of the conservative treatment of OA of the knee with really pretty good bibliography, I did this with a couple of fellows, and this was published in the Journal of Orthopedics in 2018. And it goes through basically all the injectables for patients with osteoarthritis of the knee. So what I'd like to discuss from here on out is, why should a surgeon use viscosupplementation to treat his patients with knee osteoarthrosis? If you look at the impact of high molecular weight cross-linked hyaluronic acid injections on opioid use, this was published by McIntyre in 2017. And what they found was that patients who had degenerative arthritis of the knee had a decrease in usage of opioids. So the good news is, it does seem to reduce the amount of opioid use, at least in this single study. But there are 152,000 patients in this study, so it was a significantly high number of patients that this was tested in with respect to the comparison. Here's another study that was at an abstract at a meeting in the Journal of Managed Care Specialty Pharmacy, and then eventually published. And what they found was high molecular weight viscosupplementation. There was a significant reduction in the average number of days on opioids and in the mean total amount of opioid use for patients using opioids greater than 2 months before or after having a high molecular weight viscosupplementation injection. So we do again know that using high molecular weight viscosupplementation, cross-linked as well, does affect the amount of opioid use that does occur, and is definitely decreases it. So let's take a step back. What is hyaluronic acid? Well, we know it's the major hydrodynamic component of joint synovial fluid. It's produced by type B synoviocytes in the synovial lining and fibroblasts of the synovial membrane. It has a molecular weight of 5 to 7 times 10 to the 6 Daltons or kilodaltons in a young individual. It's derived from fractured hyaluronians, which is extracted, believe it or not, from chicken combs. In 1997, it was first approved for human use in the US, and it was used by ophthalmologists. There are 3 injectable hyaluronic acids in the US that have cross-linked hyaline, and all products are avian derived except 2, which are derived from bacterial fermentation. Now, the viscosupplements that are approved in the US are listed here. Many of these are very low molecular weight up to very high molecular weight. What's really interesting, and I've had the luxury of visiting several different countries and talking about treatment of osteoarthritis of the knee over the past decade. And in some countries that don't have an FDA, they may have up to 50 different viscosupplementation preparations. This is a slide basically from some of the ones that occurred in Malaysia when I visited there for a grand rounds 7-8 years ago. So this slide is extremely important because this points out that the molecular weight in millions of Daltons in healthy young synovial fluid is about 6 million Daltons with a very high elasticity. If you look at osteoarthritic synovial fluid in young patients, it's only about 1.9 million Daltons with a very low elasticity. Drugs such as Synvisc 1, Gel 1, Durolane are high molecular weight, cross-linked preparations, and you can see they have a very high molecular weight and very high elasticity. Other ones like Hyaluronic, Suparts, Orthovisc, Uflex is kind of right at the border, have lower molecular weights and very low elasticity in some cases. This becomes important because it affects the amount of time that this material stays in the joint. And this is a study by Altman out of California, where he reviewed 68 randomized studies, level 1, 2s, with 26-week minimum follow-ups. He defined high molecular weight as greater than 3 million kilodaltons, and he found that they had greater efficacy than low molecular weight, less than 3 million kilodaltons in all studies. Thus, the advantage of using a high molecular weight, cross-linked compound. So we know that the high molecular weight viscosupplements mimic the molecular weight of normal, young, healthy synovial fluid, as I showed in that one table, and it increases the term residence time, which is the amount of time it sits in the joint, so that hyaluronic acid has more time in the joint to exert its positive effects. So, as I pointed out, the concentration and molecular weight of hyaluron molecules is decreased by 33 to 50% in osteoarthritic synovial fluid. And thus, the ability of synovial fluid to lubricate and protect joint cells and tissues is clearly compromised. You also get a loss of glycosaminoglycans in the cartilage, which causes brittleness and decreased resiliency of the matrix with age. So what does it really do? Well, it enhances chondrocyte metabolism. It decreases chondrocyte apoptosis or death. It stimulates the synthesis of endogenous hyaluronic acid from the synovial membrane, and it decreases shear, which is secondary to increased viscosity and decreased elasticity. So the question I always ask the audience when I'm talking about this, the hyaluronic acid molecules in all viscosupplements, are they all cross-linked? And it's a question of yes or no. Well, the answer is clearly no. There are many that are not cross-linked and are out of the joint in a very short time frame. Cross-linking increases the residence time of the hyaluronic acid in the knee joint, as does the high molecular weight. And the answer to this one is clearly yes. Again, that's the amount of time that material will stay in the joint. Cross-linking can increase the half-life up to 8 days. One particular study of one particular high molecular weight cross-linked visco states it can be up to 28 days, which then increases the residence time in trace amounts up to 26 weeks. But this is interesting. Without cross-linking, the half-life of viscosupplement compounds can be as short as 3 to 20 hours, and excretion, the hyaluronic acid additive, can then occur in the first 24 hours of administration because it has a very, very short residence time. So prolonged residence time results in increased production of endogenous hyaluronic acid, or hyaluronan, and it increases the inhibition of matrix metal proteinases. These are the materials that break down the surface cartilage and are important to inhibit. Now, there's also several studies that have been recently published that confirm delayed total knee arthroplasty with high molecular weight cross-linked hyaluronic acid. This is a study by David Waddell from Baton Rouge, Louisiana, looking at a cohort of about 1,863 of his patients. He had a lot of these that had grade 4 OA as a subset, but the majority of these had grade 1 through 3 Kellgren-Lawrence changes. And what he found was that total knee replacement was delayed about 7 years in 75% of these 1,800 patients. There's another study by Ong in the Journal of Arthroplasty. In his particular situation, when he looked at these, he found that the delay was 6.7 to about 14.8 months. It was a significantly longer time from the diagnosis of OA to total knee arthroplasty when utilizing intra-articular hyaluronic acid. Here's another study by Altman looking at 182,000 knee OA patients. Again, he found in the mild to moderate OA patients that the injection of hyaluronic acid was associated with a delay of total knee by an average of 3.6 years compared to those who did not get any hyaluronic acid. If you look at this study further by Altman, the delay was 1.6 years, but it increased with each additional course of HA, and that's how he got to the higher number. This is a study by Nichols published in 2019. And what he found in 50,000 patients with knee OA, that if you did one hyaluronic acid course, 28% had a total knee within 3 years. But if you did up to 4, only 10% had a total knee within 3 years. And if you did greater than 5, 5% had a total knee within 3 years. So there is some evidence that the more you give on a regular basis, the longer it will delay the need for a total knee arthroplasty. And he found that, as I stated, a repeated HA injectable every 6 months may delay the need for total knee arthroplasty in a significant fashion in this very large patient cohort. This is Nichols' study again, and this was interesting from the outcomes perspective because early to moderate OA had significantly greater improvements in pain. And the truth of the matter is, late OA, there wasn't a significant difference between hyaluronic acid versus saline. So it's really best to use an early to moderate knee osteoarthrosis. There are some other studies that have been published. This summarizes them as we spoke about a couple of these, and they, again, all show a delay in the need for total knee arthroplasty. So here's a study by Wang, which I found very interesting, published in 2011. And this is a prospective randomized study with 2 groups of 39 patients. He did a 2-year follow-up, and then he measured tibial cartilage volume. And what he noted is that the high molecular weight cross-linked visco group had increased cartilage preservation, in other words, no decrease in tibial cartilage volume, compared to the group that did not get high molecular weight visco. And those patients did get a decrease in cartilage preservation. So the group that did get the hyaluronic acid didn't change the tibial cartilage volume, but those that did not, it actually decreased at 2 years. Another study out of University of Pennsylvania by John Kelly, the question was, did it increase in type 2 proteoglycan if you gave high molecular weight visco the hyaline cartilage cell proteoglycan? So here, if you look at this, and this is a very small study, but what he did is he used T1-row imaging, which is a very sophisticated software program, a Tesla 3 scanner. And what he found in 10 patients, when he scanned them after 6 weeks of getting the injection of high molecular weight cross-linked visco, is that there was an increase in proteoglycan by 7 to 10% in the superficial cartilage of the patella. So the bottom line is, if you look at the Wang study, and then if you look at this study by Kelly and Shaw, there has to be some biochemical event occurring after you inject with viscosupplementation. Is it useful in the post-arthroscopy patient? So I actually did a couple of these reviews and published them with David Waddell. And what we found is when we looked at the meta-analyses in the literature, there was improvement in symptoms in the majority of articles with decreased pain, pain upon motion, and crepitus at the 3 and 6 month follow-up. So for me, if I see a patient after I do a knee arthroscopy, say for a meniscectomy or some cartilage restoration procedure, and they have grade 2 and grade 3 changes and they're young, I honestly don't know what else to do for these patients. I literally inject them with a high molecular weight visco for the rest of their lives every 6 months. And I've literally been utilizing this approach for over 15 years. If Wang's study is true, if Kelly's study is true, hopefully we're improving the biochemistry of that particular cartilage cell by doing the repetitive injections. So here comes the question that I'm always asked, is that there's so much information out there showing the efficacy of high molecular weight cross-linked viscosupplementation. Why did the American Academy of Orthopedic Surgeons come out with a strong recommendation against its usage for the treatment of knee osteoarthritis? And for those of you who are not familiar with the clinical practice guidelines, which have been published from the Academy, their goal really was to try to train orthopedic surgeons on what works and what doesn't using evidence-based material. But unfortunately, there's been some problem with this, and I'll explain why I say that in just a moment. Dr. John Richman from New England Baptist, who's a past president of the Arthroscopy Association as well, was the chair of this clinical practice guideline in 2008. They came out with an inconclusive recommendation for its usage, and everybody was still capable of using it until 2013, when a different group came along, a different chair of the research committee at the Academy. And what happened was they came out with a strong recommendation against its usage. They also came out with a strong recommendation against participating in strengthening, against acupuncture, not use of glucosamine chondroitin sulfate, no usage of hyaluronic acid, as I stated, and no usage of arthroscopic debridement. They felt that participating in strengthening aerobics was appropriate and non-steroidal anti-inflammatory drugs was appropriate. So here's the problem. The AOS CPGs specifically used patient-based outcomes as the ultimate goal. However, the quality and usefulness of CPGs is determined primarily by the strength and clarity of the underlying evidence using really only L1 studies. And despite the fact there were 1,100 articles submitted, they ended up using between 7 and 11 articles to make their determination that they felt were most appropriate. So case reviews were thrown out, and they used the MCII and MCID guideline to make their determination whether or not hyaluronic acid was appropriate. The other thing that they did is they lumped all the hyaluronic acids together, low molecular weights with high molecular weights. And as we know, most of the low molecular weights don't do better than saline. So that really kind of messed up the conclusions that they drew and really confused the data that they had. So one of the questions is that I like to use as an analogy, are L1 studies really the best? And a lot of L1 studies are self-determining situations. In other words, here's an example. How many of you would participate in a prospective randomized trial as to whether parachutes really work? So if I take there's 20 of you in a room, with 10 of us go up in a plane, 10 of you get parachutes, 10 of you don't, and you draw out of a hat which group you're in. Well, obviously you're not going to participate in that because it's well known how it's going to end up, right? So when I was part of the Arthroscopy Association board, we actually had Rave Bonaru from Tufts, who was a nationally known epidemiologist and statistician, and he looked at these guidelines. We asked him to do an independent review, and he felt that the AAOS methodology contained numerous flaws. This was published 2015 in the Journal of Arthroscopy. I happened to be at a meeting in Austria, and one of the very close friends with the gentleman who actually wrote and invented the MCII and MCID metric, Felix Angst from Switzerland. And I was talking to this gentleman about it, and I said, gee, could I contact Dr. Angst? And he gave me his email. So I sent him a note. I sent him all the information from the Academy. I sent him Dr. Bonaru's criticism. And this was his comment back to me This is just a summary of it. But he stated to me, "Thank you for confronting me to this interesting criticism of Bonnaroo and you against AOS guidelines 2013 for recommendation of intra-articular hyaluronic acid." And English is not his first language, but he did state to me that I can confirm complete agreement to you and Bonnaroo, especially in the following points. And he attached a slew of literature. And they went on to say that his metric that he developed was misinterpreted. When I confronted the Academy about this, they were very upset with me. And the gentleman who was a physician and the researcher really disagreed with Dr. Angst as to how his metric should be interpreted, which kind of blew us all away, but it is what it is. That was the response. Unfortunately, when insurers see a decision like that, they jump on it with both feet because it means they don't have to pay for something. So right after the AOS guidelines, Kansas jumped in first, and the Blues in Kansas said, "We're not going to cover this anymore." And you can see this happened all around the country. And now there's about 35 states which don't allow viscosupplements or use it only in extenuating circumstances through a significant pre-approval process. Not true with Medicare, however, and I'll explain that in a minute. What's an interest to me is that Blue Cross Blue Shield eliminated coverage for visco in 2013 in Kansas. They had a 500% increase in total knee arthroplasty in their first year. I don't believe in coincidence, but it is interesting, isn't it, that it happened as soon as one of the other conservative care modalities that we use prior to total knee arthroplasty was eliminated. So as of this time, there's non-coverage decisions in 35 states. Recently, last year, Anthem decided not to cover hyaluronic acid, and that raised a total of over 70 million Americans out of 185 commercially insured, not Medicare and Medicaid, unable to be covered. So let's briefly look at the literature that was somehow ignored in the JAOS article, and I'll show you that in just a minute, again, condemning the use of hyaluronic acid. There's been a review of 7 articles written in the past 6 years, including the recommendation from the CMS, which is an independent entity. I'll show you that in just a moment. But the combination review of over 65,000 patients in multiple meta-analyses, including 2 Cochrane meta-analyses. Cochrane's from Great Britain, who started the meta-analysis concept in the 90s. And they found absolutely no correlation with meaningful clinically important improvement and meaningful clinically important differences, which is the Felix Angst metric I was just talking about, which is all the Academy used to refute the usage of high molecular weight visco. And in fact, they found out just the opposite, that the effect size was increased in patients who were treated with high molecular weight visco using subjective evaluations. And in some patient perception studies, they concluded that of all the conservative approaches, viscosupplement was the highest rated treatment. This is from the patient perspective, and I'll show you one of those studies in just a moment. A repeat Cochrane analysis was published in Clinical Orthopedics and Related Research by Evan Yu in 2014, and he concluded that in this Cochrane review, overall benefits to viscosupplementation in comparison to placebo for pain, function, and patient global and assessment scores was improved. Now, this is what I was referring to with respect to CMS. They use someone called the Agency for Healthcare Research and Quality, AHRQ. So when they were confronted with whether or not they should cover for Medicare viscosupplementation, they had AHRQ actually do a very extensive review of viscosupplementation literature. What they found is there is insufficient evidence to recommend for or against the use of intra-articular hyaluronic ion injection in patients with OA of the knee. This is very similar to what Dr. Richmond and the CPG in 2008 with the Academy found. However, it may be considered for patients who have not responded adequately to non-pharmacologic measures. Now, again, they had the whole gamut of viscose, not just high molecular weight cross-linked, everyone that was out there that had been approved. So CMS allows for us to use viscosupplement, in other words, on Medicare patients. Let me just show you a few studies very briefly here. In January 2015, Banneroo reviewed 137 studies, 33,000 participants. Most efficacious treatment of all the different injectables was hyaluronic acid, and it was significantly superior to oral placebo. It was interesting, all treatments except acetaminophen showed significant improvement from baseline pain. Here is Pericope's study from the Journal of Arthroscopy, a systematic review of 49 trials, 6,900 patients. The effect size favored hyaluronic acid. By 4 weeks, peaked at 8 weeks, and had residual effect at 24 weeks. Here's a study by Strand, total of 29 studies, over 4,800 patients. They used saline as a control, and visco had large treatment effects between 4 and 26 weeks for pain and function compared to pre-injection values. Here's Campbell's study in 2015, 20,000 patients, level 1 through 4 Kellgren-Lawrence changes. And they looked at intra-articular hyaluronic acid, non-steroidals, intra-articular steroids, and placebo. They found that hyaluronic acid provided clinical improvement in pain and function compared to all other modalities up to 26 weeks. They concluded that there was a high level of evidence to suggest that intra-articular hyaluronic acid is a viable option for knee OA, and its use should be considered in patients with early knee OA. Now here's one of the best studies, and this is from the JBG Reviews from 2016. And it's entitled Viscosupplementation in Knee Osteoarthritis, Evidence Revisited by Joe Hall from Canada. They found that higher molecular weight and cross-linked formulations were a safe option in patients with knee osteoarthritis. They went on to say that a careful exam of the most recently published articles suggests that viscosupplementation, high molecular weight cross-linked, is a safe option with a clinically important reduction in pain for younger patients with knee arthrosis. And they went on to specifically state in those formulations with high molecular weights or hyaluronic acid cross-linking, again, high molecular weight or hyaluronic acid cross-linking, which is different from low molecular weight, non-cross-linked compounds. So let me go back to one of the studies that I was going to tell you about in looking at it from a patient perception standpoint. So what are the patient perceptions of treatment with high molecular weight viscosupplementation? Now, this is a study out of Europe from Posner. And what he did is he did a prospective internet-based double-blind survey, and he recruited adult participants with self-reported osteoarthritis of the knee from Germany, Italy, France, Spain, and the UK. They were blinded to the study sponsor, which was Sanofi, which means they got Synvisc. And they had a total of 2,000 participants, 400 from each country, in line with the target sample size. So they were asked about their diagnosis, their treatment history, perceptions about the effectiveness of each treatment. And then it was followed by a discrete-based conjoint exercise to identify the preferred attributes of their osteoarthritis of the knee treatment. So they participated in exercise, PT, acupuncture, magnetic pulse therapy, topical creams, glucosamine, oral pain meds, non-prescription. Some had some oral pain meds. A lot of them had COX-2 inhibitors. Some had narcotics. They had steroid injections, viscosupplement injection, arthroscopic knee surgery, and all combined then determined whether they were satisfied, moderately satisfied, or very satisfied. So if you look at the right-hand side, you can see that when you combined everything, it was about half and half. But the truth of the matter is those patients that had the highest satisfaction rate at 66% were those that got high molecular weight cross-linked viscosupplementation. Again, looking at exactly the same modalities that we talked about on the left-hand side. And you can see when they asked about the perceived effectiveness, again, the highest amount was 74% for viscosupplement. And you can see here, everybody said they got some perceived effectiveness, but no one was over 68% except for viscosupplement. The narcotic patients actually were at 68%. So if you give them narcotics, perhaps alcohol would have the same effect, I don't know. But the highest perceived effectiveness was viscosupplementation. Now, what's really interesting is that when I refer to the Journal of American Academy of Orthopedic Surgeon article, Dr. Carlson et al. Was writing an article about compliance with the AOS guidelines for treatment of OA of the knee. And he was commenting on a survey of the American Association Hip and Knee Surgeons, AAHKS, which I'm one of the founding members as well. And what they found was, of the 345 responses, most of the surgeons did use viscosupplement for OA of the knee. It obviously decreased dramatically when they got to grade 4 changes. But it was the most commonly selected intervention not recommended by the AAOS for Kellgren 2 and Kellgren 3 changes. Dr. Carlson stated, well, apparently the AAOS guidelines on the treatment of OA have not reached the orthopedic community, resulting in a lack of treatment consensus and continued use of modalities with absolutely no proven patient benefits. He went on to say that despite the fact that intra-articular hyaluronic acid is not recommended for symptomatic OA of the knee, it appears that the AOS guidelines have not effectively reached the orthopedic community. So given the disparity between the recommendations and actual practice, the orthopedic community needs education regarding the efficacy of this modality. So apparently those of us who use it have not been educated, according to Dr. Carlson. So when I went and read this article and looked at the references, not a single reference that I mentioned representing those 65,000 patients was utilized in this bibliography, which makes me believe this is an extremely biased, poorly chosen use of the literature articles that he obviously was trying to make a point here. So Dr. Andy Spitzer from Mount Sinai in California, I wrote a letter, and basically we stated that it's really ridiculous what was concluded in that article, because the AOS mission statement is to champion the interests of all patients. And as Jim Lubowitz, who is the editor for the Journal of Arthroscopy, correctly stated, it is not in the interests of all patients to recommend against a treatment that is of significant benefit for some patients, especially when that treatment is for a disease that is not preventable and for which there's no cure. And as I showed you with the patient perception article, the highest rated treatment that patients thought worked the best was viscosupplementation. We actually went ahead at Specialty Day 2 years ago and had 290 participants in the audience, and we asked them to participate in this particular online usage of viscosupplementation. And you can see that well over 90% of the members of the American Orthopedic Society of Sports Medicine and the Arthroscopy Association of North America do use hyaluronic acid. They also felt that it results in comparable reduction of osteoarthritic knee symptoms compared to steroids. And also with respect, there was sufficient medical evidence to support its use in over 82% of patients. And the majority of individuals had experienced negative coverage determinations when trying to use it by insurers. So clearly, at least as a result of this particular survey, most everybody believes it's useful, and most everybody believes there is, despite what Dr. Carlson says, medical evidence to support the usage of AHA for management of symptomatic OA that I've tried to show in these slides. Well, what about the economics of care? There's something called quality adjusted life years, and that takes into account both the quantity and quality of life generated by healthcare interventions. It's used in economic evaluation to assess the value for money for medical interventions. And one QALY equates to 1 year in perfect health. Well, it's really interesting. Hatum did a study on the cost effectiveness in visco, and he found that there was about a $38,000 incremental cost effectiveness ratio, which means the responders with OA knee pain actually do pretty darn well. And therefore, from a cost effectiveness standpoint, it's worth doing. And this was his evaluation of the actual cost effectiveness of utilizing hyaluronic acid. There's several other studies that have been published, and one other study indicated that the quality may be as high as $12,800 per year with avoidance of surgery. So this is from last year and actually updated in February, that the Arthroscopy Association and AOSSM each have 2 advocates on the CPG Review Committee meeting, which occurred in February. They're slated to meet again in November to hopefully modify the recommendations regarding usage of visco to comply with the recent literature confirming the efficacy of high molecular weight cross-linked visco, which was, interestingly enough, the conclusion from the Academy's own journal, the Journal of Bone and Joint Surgery. And you can see Felix Angst here in this article that was published in 2019. He also went on to say that it was very important when looking at MCII and MCID to note that the Academy inappropriately utilized his metrics. So in conclusion, high molecular weight cross-linked viscosupplementation is useful for the treatment of patients with grade 1 through 3 changes of osteoarthritis, and even in patients with grade 4 changes with joint space collapse when nothing else has worked. And it can postpone total knee by an average of of 3.8 years up to 7.6 years. High molecular weight cross-linked visco does decrease pain and increase function, as evidenced by the studies that I've shown. Cross-linking of avian-derived visco increases residence times and improves symptoms up to 26 weeks. The effect size of high molecular weight cross-linked visco results in a 38% improvement in pain relief in all of the FDA-sponsored studies that have been published. The addition of high molecular weight cross-linked visco to bupivacaine injected joints and cold storage allografts actually reduced chondrocyte death, apoptosis. This was presented by Dr. Felix Angst, who's chair at Tulane and our second VP for the Academy. It also appears helpful after arthroscopy of the knee when early OA is noted at the time of surgery. It appears to decrease existing osteoarthritis progression after injection at 2-year follow-ups and may increase proteoglycan content of the hyaline cartilage cell after injection. Economically, it reduces the cost per year of OA treatment significantly and may postpone the necessity of total knee arthroplasty as stated by a minimum of 1.2 years. So finally, the misuse of the MCII and MCID metric by the AOS has been confirmed by the developer of the metric, Felix Angst, and the AOS strong recommendation against usage of visco should be clearly reevaluated, which is being done at this time. The recent 2016 JBG review of 99 articles confirms the efficacy of high molecular weight cross-linked visco in the treatment of mild to moderate osteoarthritis. The American Academy of Orthopedic Surgeons has agreed to reconsider its evaluation of the usage of high molecular weight visco in the non-arthroplasty guideline CPG, and it will announce its recommendations late 2019, but this is postponed now to November 2020. And as stated, they've met in February and are meeting again in November of 2020. And this delay, quite frankly, is due to the COVID pandemic. Finally, on behalf of the Arthroscopy Association 2 years ago, I submitted a thorough literature review to Dr. David Halsey, who was the president at that time. Dr. Halsey and several of the past presidents use visco in their patients with mild to moderate knee osteoarthritis, literally on a weekly basis. So I hope this has been some help in understanding the usage of viscosupplementation and treatment of OA of the knee. And I'll be happy to try to answer questions at this time. Thank you for your attention. So one of the questions that was posed is, I've heard from many generalizations that total joint docs just want to take the patient to total knee, so they won't want to delay the surgery. So could that be why some physicians don't care about the quality or efficacy of visco treatments? What are your thoughts on this? I think it's a great question. I do a knee clinic every Monday, and I see about 25 to 30 knees, most of which are osteoarthrosis. And it never ceases to amaze me how many of those patients have been scheduled for total knee replacement with grade 1, even grade 2 changes on their plain films, Kellgren 1s or 2s, not even 3s. And I always ask them the question, have you tried Visco? Have you tried PRP? Have you tried steroid injections, even a long-term like Zilretta? And the answer is most of the time, no, or I tried a Visco, which in my opinion wasn't an efficacious Visco. And so my approach to this is because of the fact that more and more docs now are doing total knees and unis on patients, even some in their 30s. I've seen 2 unis on patients in their 30s, which absolutely blows me away. And the average survivorship of a total knee is right around 15 to 18 years. And we know that only 80 to 82% of patients are happy with their total knees. I want to delay that as long as possible. So the bottom line is that some of the Viscos are efficacious. A significant number are not. As you heard from my talk, if you look at the data, especially the JBG Reviews by Joe Hell, the high molecular weight cross-linked Viscos are really the ones that work the best. And in my opinion, those are the ones that anybody should be using. When you're looking at a Visco to use, remember to look at its molecular weight. Think of Altman's study. Less than 3,000 is not considered high molecular weight. He's pointed out in his meta-analytic study that was published in AJSM in December of 2016. Joe Hell is basically pointing out the same thing. So for me, I try to postpone total knee as long as I can, especially when I think of a 38-year-old that had a uni, is going to need 3 revisions in his lifetime. And the success rate of revisions drops 10 to 15% with each one. So it's pretty sad, really, quite frankly. I mean, that patient should have had, in my opinion, a proximal tibial osteotomy, maybe a cartilage transplant in addition to it. So to the answer that specific question, you may be right. Maybe they don't care about the quality or efficacy of Visco, have used a low molecular weight one that hasn't worked. So I guess that's how I'd respond to that particular question. The second question is, do you think the AOS will ever recommend Visco in the future? So I've been involved in this particular push to try to overturn this since 2013. The CPGs, the clinical practice guidelines that the Academy puts together with the committees, and I was on one, 15 years ago for anterior cruciates, are supposed to be revised every 5 years. So in 2008, when John Richmond chaired that particular non-op osteoarthritis CPG, it came back for Viscos as questionable. So none of the insurance companies responded to that, right? So then in 2013, it was a different group. And they decided, based upon 7 articles out of 1,100 they reviewed, that used a metric, which the developer of the metric, Felix Angst, said was used inappropriately. And I refer you to Banner's study and Lou McIntyre's study in the Journal of Arthroscopy regarding the criticism of that. And so for that reason, the AOS has really postponed making a decision on it. They were supposed to make a decision on it in 2018. It's been postponed to 2020. Because of COVID now, the decision won't be made until November. So as I illustrated or tried to state in my talk, the Arthroscopy Association, AASOM, American Association of Sports Medicine, has 2 individuals that are on that committee, both from both organizations, who very strongly that we should be limiting the approval to high molecular weight crosslink based upon the most recent studies that have been published. I'm fairly optimistic that by November, talking to some of the people that are from ANA that are on that committee, that we're going to be able to differentiate high molecular weight from low molecular weight. And again, when you choose a Visco, make sure you look at that molecular weight. I'm not going to name them, but some are only 600,000 versus 100,000 versus 6 million, Dalton. So you got to make sure that it's high molecular weight and it's cross-linked for it to be effective. So the answer to that question, I'm optimistic that it will happen. And as you know, in over 35 states, and now with Anthem stating they won't cover it, Medicare does in all states, that puts basically out of the 185 commercially insured patients, only about 50 to 60 million that are covered. They're covered in Minnesota and Wisconsin for the most part, but in other states, there's no coverage whatsoever. So That's exactly right. Now the question is, and I sort of answered it, all the viscos market themselves as high molecular weight. Well, that's absolute nonsense, because read the data that they put. It's a marketing tool. It's just not true. So again, when you're looking at viscos, you want the ones that are closer to that one slide that I showed is 6 million Daltons, which is normal hyaluronic acid in an 18 to 25-year-old male. There are three that I can mention that are high molecular weight, and it's Synvisc, Durolane, and Gel 1. Some have an infinite molecular weight. They're all cross-linked. So those are the three that I utilize personally for that reason, because I think it's very important to understand that if you inject somebody with saline and then you inject them with low molecular weight, even if you do 3 to 5 injections, the success rates are about the same. Now, having said that, there's a tremendous placebo effect. Look at that Posnet study that I used as a slide. Even patients who got any type of treatment for OA, 50% got better. There's a question here about Euflexa. It is borderline. It's 2.4 to 3 million Daltons. It's really about 2.5 million Daltons for the most part. So it's really borderline. And so for me, I don't use it. The bacterial fermented products, you don't have to worry about getting a pseudosepsis like you do with Synvisc. And one tip for all of you who use Synvisc, by the way, it has about 7 micrograms of protein in it compared to Gel 1, which has 0, and the others that have 0. And so there is a small instance of pseudosepsis. And so when I have if I have a patient that can only get Synvisc based upon their insurance, especially if they're from out of town, I put 1 cc of steroid. I aspirate the 1 cc of steroid with my 6 millimeters of Synvisc, and I inject them simultaneously. There's 2 published studies that show, one is Stedman and one is out of Latin America, and I'm sorry, I can't think of the name right now, that shows that if you give 1 cc of steroid, 2 things happen. As Waddell has pointed out, it does not break down the Synvisc structure. That's number 1. Number 2, it reduces the incidence of pseudosepsis to 0. And I've injected 300 patients with Synvisc and 1 cc of steroid, Depo-Medrol is what I usually use, or even Celestone, over the past 12, 13 years, and never had a single case of pseudosepsis. But pseudosepsis, when they come into the emergency room, their knees swollen up, the ER doc aspirates it, it looks a little discolored, so they assume it's an infection, which is absolute BS. Then they get admitted, put on high dose Ancef. I had 4 of those back literally over 12, 15 years ago before I started using Celestone or Depo-Medrol with it, and have had 0, knock on wood, since then. And there's a comment here, is there an advantage in giving, question, pardon me, is there an advantage in giving Visco more than every 6 months? That's really an outstanding question, because the residence time of the high molecular weight cross-linked Viscos varies, but it's up to 26 weeks. So that covers the 6-month time frame. There's one study out of India where they gave it every 3 months and showed better results than giving it every 6. That was with a high molecular weight viscose supplement. The trouble is, in states that approve it, the insurance plans do not allow for reimbursement, so the patient would have to pay for it. Have I ever done it more frequently than every 6 months? I have, in some professional athletes, actually, and they've loved it. But I haven't in the common individual. They have to pay cash for it, which can be expensive. And one comment I wanted to make, it was in one of the other speakers' notes. You're not supposed to do a total joint within 3 months of giving steroids. So Tom Skulko at the Knee Society, in over 56,000 joints, when he looked this up, and he actually presented it about 15 months ago at a summer meeting I was at, found that viscose supplement has exactly the same incidence of infection if you give it within 3 months preoperative of the time of a total joint. Very few people know that. He presented that at the Knee Society, and he's publishing it. So think about that for a second. If you've got a patient with advanced disease, Kellgren 3-4, you want to give it one last chance, and you're planning on doing a total joint, I would avoid visco. I would clearly avoid a steroid within 3 months of the time of surgery. We don't know with Zilretta, which is can sit in the joint for up to 6 months, how long you should wait. Most people use Zilretta, which is a long-acting steroid encapsulated in a little microcapsule of PGLA. What happens is that sits on the synovial surface and gradually gets absorbed. And so the bottom line is that's probably a drug I would not do a total joint on within 6 months, because if they did get infected, and you're concerned about liability, I suppose there's a small chance you would be liable. Does Medicare cover high molecular weight hyaluronic acid? The answer is absolutely it does. HQRS, I think I showed on my slides, one of the previous speakers did cover that as well. So Medicare is not an issue for high molecular weight hyaluronic acid. It's been reviewed by the Agency for, let's see, it's Healthcare Quality, I think it's called. It's on my slide for those who want to see it. They looked at it because of the Academy's recommendation, and Medicare deemed it was safe to use in patients with low-grade arthrosis. So it's not a problem in a Medicare patient. If you want to use a self-pay approach with patients as well, where it's not covered, you can do that in addition. I guess the only other point I do want to make for those of you who are still listening is, I think it's critical to recognize that people are living up to 90 to 100 now, especially you young folks that are part of the audience. And I think it's very inappropriate to be putting total joints in extremely young patients. I have this argument with the total joint surgeons all the time at meetings, and they make the argument, yeah, but then your patient can get back to low-grade sporting activities, skiing, pickleball, for example, or doubles tennis, or running activities that are not significant. But the truth of the matter is, if you can postpone totally as long as you can, it's a tremendous benefit for that patient. And secondly, because we have this high incidence of obesity, the failure rate on total joints is only going to increase with time in these obese patients who absolutely don't want to lose weight. I published an article years ago about patients who lose weight after total joints, and it was less than 10 to 15%. I mean, this is a 20-year-old article. But the bottom line is, I would urge all of you who are listening to this webinar to try to postpone it as long as you can, especially with the success rates only in that 80 to 82% success range, and understanding that every time that you do a revision, you're dropping that success rate rather significantly. Plus, you've got the incidence of infection, which of course is very low. So, for me now, I'm doing all my joints as outpatients. I optimize my patients. I will not do an outpatient joint, obviously, on somebody who's obese, anybody with a comorbidity. So I'm being very selective with respect to this. And sure, there's a lot of folks who need them that are obese, but I think we all have to use pretty good judgment. So there's one final question here, and I'll wrap up. There is no advantage to multi-dose Synvisc. In fact, I would make the argument there's a greater chance you're going to get a reaction to it. There is one study that shows that it's 2%, 6%, 8% with the third injection. So I always do a singular injection, and I would have a very low tolerance for adding a CC steroid. I hope that answered your questions, and thank you very much for your time.